So I'm going to talk about ORBITA-2, and this is my disclosure. So this is an important trial for was presented in AHA last year. This is a trial, as you know, as interventional cardiologists, we always struggle between a PCI, which is stenting, to medical therapy. And these are trials that you probably know about quite a bit over time. Is that the COURAGE trial in 2007, which compares using PCI compared to medical therapy. And at that time, it's old stents, old sort of treatment. We always poo-poo it because we thought it was not really a modern therapy. But nevertheless, it didn't really show a whole lot of advantage of PCI. Then this ORBITA-1 trial was 2018. Essentially, if you maximize patients with medical therapy, PCI doesn't really add a whole lot in terms of stress, timing, or also in terms of their sort of symptoms. So, and then obviously the ischemia trial that was sort of presented and various part of it coming out in 2020, really again showing people who have ischemia that even though treating with PCI still doesn't add a whole lot, except there might be some better relief of angina. So the ORBITA trial is the trial that was performed in the United Kingdom with 14 sites. Essentially what they're trying to do is to test whether PCI as a treatment, does it help patients with angina as a single therapy without necessary medicine, which is a way to really sort of test the ability for stenting, for example, in these patients to relieve their angina and see whether outcomes are changed as well. So 923 patients, and many of them obviously got sort of screened and then pre-randomized, and then eventually 300 or so went randomized to PCI, about another sort of between two groups. There's a one-to-one randomization, and basically what happened is that there's 2 weeks of washing out the medicine, meaning that medicine they were on is sort of stopped. There's sort of some benchmarks or sort of bumpers to make sure the patient doesn't fall off, meaning too much angina and too much other symptoms. But then after 2 weeks, they are randomized to PCI or to placebo control. So everybody undergo a catheterization, and that get tested if they need to be using the pressure wire, FFR, and so forth. And then if they're positive in terms of FFR, they will get their lesion treated. So it's a really quite novel way of approaching this problem to ask the question, is PCI just as good as medication, or is it better than medication to start for patients that have lesion, ischemia, and symptoms? So inclusion, again, they have to be suitable for PCI because that's the time when they randomize during the catheterization. And they have to have some angina, they have to have some evidence of stenosis on previous angiogram or CT, and also ischemia. Exclusion are the typical ones. I'm not going to go through that too much. And these are the statistics. Again, interesting statistics because this is a new way of measuring some of these outcomes, meaning the measurement of how much angina you have as well as how much medicine you have. So it's combined together, called an angina score. This is a sort of table of the characteristics of these patients, very similar to what typical a UK system of how these patients are majority of male, and obviously the diabetic patient population are about 20%. And most of these patients have essentially one vessel and sometimes two vessels, and most of them have Canadian score, a class of 2. So some angina, but obviously not unstable, not severe. And basically then undergo the randomization after they have an angiogram and testing for lesions. So the data basically is these patients' self-reported angina score plus how much medicine they have. And these are the number of patient days that has been collected. And at 12 weeks, this is a 12-week trial, the mean angina symptom score is 2.9 in the PCI group and 5.6 in the placebo group. So obviously statistically significant to a p-value of 0.001. The daily angina frequency is also less, statistically significant. The angina medication is about the same. So this is a sort of a complex slide that you don't usually see it presented in this way. But if you look at the top panel, essentially what you can see, one arm is the PCI arm, one is the placebo. And in green shade in the bottom is basically the patients, proportion of patients that have essentially no angina, no medications. So you can see on the PCI arm, there's more green over that period of time of follow-up of 12 weeks. And then you can see the next one, which is angina, but not really on any medications, and then subsequently angina, medication, so forth. So proportionally, more patients are angina-free if you treat it with PCI versus medication as a first-line therapy. And the bottom is obviously the angina frequency episodes and so forth, that you can see that the PCI generally have a better sort of symptomatic relief as well as less need of medication. So I think the basic message from ORBITA-2 is that it really addressed a question that we clinician-wise and sort of clinically knows that the patients who have PCI, relatively simple lesions and so forth, you fix them, the angina goes away without have to have any medications at all. There are some patients that continue to have some chest pain, but sometimes, a lot of times, it's not really angina. And that's an issue that we'll talk about tomorrow, whether some of these patients actually have angina, but no obstructive pulmonary disease from other lesions, for example. So I think that's also a very interesting message. He left the room, so I don't.
Yeah.